Hello, friends. Now we'll be beginning our discussion on thyroid imaging. And to start with, we'll talk about thyroid nodules. Thyroid nodules are exceedingly common in general population. And all of you doing routine sonographies for neck diseases might have come across a number of nodules in your life. And you might have also come across an equally good number of questions related to thyroid nodules. The most common being whether this nodule is looking like a benign nodule or a malignant nodule. Sometimes the clinician can even ask you what to do with this nodule. Do we need to biopsy it? Do we need to FNA it? Or do we need to do nothing about it? Just reassure the patient or follow it up. So, to answer all these questions on a uniform basis, we came up with this terminology called Tirads, which stands for Thyroid Imaging, Reporting, and Data System. And it has been developed on the same lines as ORADs, BIRADs, LIRADs, PIRADs, and so on. It has two major aims. The first important purpose of Tirads is to standardize and to make the reports of radiologists more uniform as far as thyroid nodule reporting is concerned. And second important purpose is to stratify the thyroid nodules based upon their risk of developing or harboring a malignancy. So in this particular session, we'll be talking about a number of cases. We'll be looking at a number of thyroid cases, and then we'll be trying to understand the basic of thyroids, and we'll also be trying to understand what are the features which make a nodule suspicious and how are they related to thyroids. Okay, so now let's start our discussion with our set of cases. Now here I'm going to show you 5 different cases, 5 different case scenarios, and I would leave these cases to you. Now what I mean by this is I would let you decide whether a particular lesion is looking benign or not. And then we'll be talking about all these cases in detail. Fine. So let's start with our first case. Our first case is that of a relatively young female, 33-year-old female. I still remember this patient who had no specific complaints. The only complaint that she was having was a vague pain in neck. And I still remember the pain was somewhere starting on the nape of the neck. It was going all the way down. So the clinician was thinking about cervical spondylosis, but this patient was a bit apprehensive. She said, I want to get an ultrasound done. I probably have some malignancy somewhere. On examination, the physician could not find anything. She was sent for a routine neck sonography, and this is what the next routine neck sonography shows. I want you to have a look at this cine loop, and you make your own observations. I would just want you to make a presumptive diagnosis that whether this nodule is looking benign or malignant. Let us play this once again. So I hope all of you can see that there is a nodule definitely present in the right lobe of the thyroid here. So I want you to have a look at this nodule, and in your mind, you can make a presumptive diagnosis whether it's benign or not. Now, let's come to our second case. Well, this is again an interesting case. This is a case of a 28-year-old female who was postpartum. And during this postpartum period, she developed a swelling in the left side of the neck, which was painless. Now, whenever we develop painless swellings in neck, it's always suspicious because we first think about malignant lymph nodes or maybe tubercular lymph nodes. On examination, the clinician was sure that this is probably a left thyroid lesion because this swelling was not lateral, but rather it was medial in location. So let's have a look at the sonographic image. So this is the sonographic cine loop. And again, I hope all of you can make out that there is something gone wrong with the thyroid. The left lobe of the thyroid is showing a distinctive lesion. Again, I want you to do the same. Make a presumptive diagnosis. Tell me whether this lesion is benign or malignant. Fine. So this finishes our cine loop. We're done with the case number 2. Let's come to our case number 3. Now, this case number 3, again, a young female, just 31-year-old female, coming to us with swelling in left side of the neck. And there's no history of constitutional symptoms like fever, pain, or dysphagia. And this swelling was present far laterally. And on examination, the clinician was sure that this is nothing but an enlarged cervical lymph node. So this patient was initially sent to us for assessment of the cervical lymph node status, but we want something else. Let's have a look at the cine loop. So what do we see in this cine loop? Again, the left lobe of the thyroid appears diseased. There is a nodular lesion in the left lobe, and there's not one single lesion. I can see a lymph node also. There are at least 2 lesions that I can make out on this cine loop itself. Fine. Now, again, I would like you to do the same, make a presumptive diagnosis, whether we're dealing with a benign lesion or a malignant lesion. In the meanwhile, we'll have a look at case number 4, which is that of a youngest female, 22 years, just 22 years of age. I still remember this patient who came to me with no specific complaints. And in fact, when she first narrated her issues, her complaints, I thought that it was basically functional, nothing else. She complained of neck pain and odynophagia, and clinical impression was pharyngitis. But in pharyngitis, usually we do not do ultrasonographies. But this patient had already taken 2 courses of antibiotic therapy on 2 separate occasions for 2 weeks, and her symptoms were not improving. So, to rule out any other cause, the physician thought that it's better to get an ultrasound done. Examination, the physical examination of the patient, I mean, on palpation, there was nothing. There was no lymph node, no thyroid swelling, nothing at all. Now, let's have a look at what did we find on her ultrasound of the thyroid. So, there is a thing in the right lobe of the thyroid. I hope all of you can make out something wrong with the right lobe of thyroid. Again, I want you to make a presumptive diagnosis. Are we dealing with a benign nodule or are we dealing with a malignant nodule? Fine. There's nothing more to it. Now, let's come to our last case. Now, this is a middle-aged female, 38 years. Till now, all what we're dealing with are young females. Now, this is 38-year female who was having a painless left neck swelling. Again, when there is a painless swelling in the neck, it is suspicious. Either it's lymph node or it might be something else. But there was no history of fever, no constitutional symptoms. So TB was slightly down the list. We didn't think of TB. On examination, it was clear because this swelling was far lateralized, as it is nothing but an enlarged cervical lymph node. Now let's have a look at what do we see in the thyroid. So in the thyroid gland right now, I hope all of you can see that there is a lesion. Now this lesion appears to be more exophytic. Let me play this clip once again. But on physical examination, I told you that the clinician was suspecting a cervical lymph node. So I want you to have a very good look at the adjoining structures here also. Do we have a cervical lymph node? Yes, probably there are cervical lymph nodes which were palpable to the clinician. But right now, I don't want you to focus on the nodes. I just want you to focus on this particular nodule, which is more of an exophytic nodule arising from the lower pole of the left lobe of the thyroid gland. This is the morphology of the nodule, and I want you to make a presumptive diagnosis, whether it's a benign nodule or it's a malignant nodule. Now, to make it easy for you, what I've done is I placed all those 4 cases together. This is case number 1. I write 1 here, case number 2, case number 3, and case number 4. Now, tell me, what do you think is benign and what do you think is malignant? Before you go ahead, I just want you to stratify or to differentiate all these 4 nodules based upon their echogenicity. Fine. So when you talk about this nodule, what is this nodule? I think everybody of you would say, sir, it is a hyperechoic nodule. Hyperechoic nodule. Then, what do you think about this particular nodule? Does it look hyperechoic? No. In fact, it's showing almost the same echo texture as that of a parent thyroid gland. So this nodule is isoechoic. Fine. Now I want you to have a look at our third nodule. Third and fourth nodules both are hypoechoic. Fine. But amongst them two, I can see one is more hypoechoic than the other. This one apparently is the most hypoechoic of them all. So how did we make this distinction? If there is something which is very hypoechoic and less hypoechoic, is there anything anatomical landmark which is present in the neck with whom we can compare echogenicity? So we could have compared it to thyroid, but unfortunately, thyroid is a very echogenic structure. So in both these cases, the lesion is appearing hypoechoic to the thyroid gland. Do we see anything else? Look at something which is present more anteriorly. What is this? This is the strap muscle of the neck. Here is the strap muscle of the neck. So if a nodule is appearing more hypoechoic than the strap muscles of the neck, it is going to be considered very hypoechoic. I'm just going to add a very to it. So now I have 4 different type of nodules based upon their echogenicity: an echogenic or a hyperechoic nodule, an isoechoic nodule, and I have 2 hypoechoic nodules, but the other one is very hypoechoic. Now, let us try to understand which of these particular morphologies is associated with a higher risk of malignancy. So why does a nodule become hypoechoic? It is said that a nodule turns hypoechoic when it has got a high cellularity and all the cells are very tightly or closely packed with each other. What is that echogenic thing looking like? Echogenic lesions are usually benign lesions. We've seen that with liver also. In liver, if we find an echogenic lesion, it's more likely a hemangioma. In kidneys, if it's an echogenic lesion, it might be an angiomyolipoma. If you have an echogenic lesion in the breast, it is also less likely to be malignant. But all hypoechoic lesions always raise a concern. In the liver, think about what is hypoechoic metastasis. What else is hypoechoic? HCC. In kidney, what is hypoechoic? It's an RCC. In breast, what is hypoechoic? It's breast cancer. So we have learned this through our observation of malignancies in different tissues of the body, that a hypoechoic tumor is always likely to be suspicious. So I would say that just based upon their echogenicity, case number 3 and case number 4 are having a higher risk of malignancy as compared to case number 2 and case number 1. This is what Tirads also did. So Tirads used one very important sonological feature of thyroid nodule to give a scoring to these thyroid nodules. Fine. So if there was a thing which was hyperechoic, this is more likely to be benign. So Tirads said that I'll give 1 point for hyperechoic lesions. Similarly, if there's something which is isoechoic, means it is behaving very similar to the normal thyroid parenchyma. So it is also less likely to be malignant. So this also was given a score of 1. And if you have hypoechoic nodules, so both of them are suspicious nodules, so Thyroid would have to give a higher score to them. So for the nodule, which is only hypoechoic, I mean, which is hypoechoic but not very hypoechoic, a score of 2 was given. While a very hypoechoic nodule would be given a very high score, that is a score of 3. So this is the first important parameter which Thyroid uses, that is echogenicity. And based upon their echogenicity, this particular score has been given: 1 to hyperechoic nodules, remember, 1 to isoechoic nodules, 2 to hypoechoic, and 3 to very hypoechoic nodules. Now, let's come to our next special case. Again, want you to have a look at this particular nodule. Do we see a nodule first of all? Yes, we do see a nodule here. And this nodule is a very small nodule, and this nodule is a completely cystic nodule. Fine. This is a cystic nodule. When we have a cystic nodule, this nodule is most likely to be benign. Any cyst is benign. We know that in every part of the body, cyst is usually benign unless it has some solid component. So this particular nodule, which is a cystic nodule, was also classified based upon its echogenicity in Tirads. Since it is showing no echogenicity, it was called as an anechoic nodule. We know all cysts are anechoic, and thus it was given a score of 0. It means it's given the least score. It is the least likely to be malignant. In short, this was what the scoring which was given by Tirads, and anechoic would be given 0, iso to hyperechoic 1, hypoechoic 2, and very hypoechoic 3.